bariatric techniques, and are they a viable alternative to surgery? And for Dr. Sharaiha, we're going to do this via video. So if we can show the video now.
Hello, everyone, and thank you so much for the invitation. Wish I could be there with you. So my task is to talk about endoscopic bariatric techniques. Are they a viable alternative to surgery? And hopefully by the end of this talk, I'll convince you of that. These are my disclosures. So when we look at the problem of obesity in the US, you can see that there are over 200 million obese or overweight patients. And of those, 19 million are surgical candidates. That means those are BMI of 40 and above or 35 and above with one comorbid condition. And then you have 88.6 million who have BMIs of 30 and above. They don't qualify for surgery, and diet and exercise have failed. And then you also have the overweight patients, 97.8 million, and those are at risk for diabetes and NASH. And of those, only that red dot, 2% of people who are eligible undergo surgery each year. So you're left with this big treatment gap. Now, when you look at the treatments for obesity, you have diet and exercise, those least efficacious but also least risky. Then you have 7 approved medications by the FDA in the US, and we all heard about the game changer Ozempic in the media lately. And then you also have the various different surgeries, so lap band, surgical sleeve, Roux-en-Y, bypass. And what the more small value bypass, the more risk it is, but also the more efficacious, so you have more malabsorption. But as we heard, only 1 to 2% receive surgery each year. So you're left with this big treatment gap, and this is where endoscopic options have a role. Now, what's important, though, is to realize that surgery saves lives. And this is a long-term study, the SOS study that was published originally in the New England Journal and more recently in JAMA, looking at the various different surgical cohorts, and they follow them over time. It's a closed system. So you can see here the Roux-en-Y gastric bypass patients lose weight, then they gain over a period of 10 years, they plateau. But what's important is that the 20-year mark, there's still a lot less than where they started off with. They compared the Roux-en-Y vertical banded gastroplasty and the lap band. And at the end of the follow-up period, you can see the total body weight loss was 14% in the lap band, 16% in the vertical banded gastroplasty, and 25% in the Roux-en-Y gastric bypass. But what was more important is that the rate of death was a hazard, there was a reduction in death in the surgical group compared with the sort of no treatment group, suggesting that bariatric surgery saves lives. Not only does it save lives, but it also improves or treats diabetes. And this is a randomized study of sleeve gastrectomy, gastric bypass versus medical therapy over 5 years. You can see at the end of the 5 years, the total body weight loss in the surgical groups versus the medical group. But what was more important is that the treatment success at 5 years, defined as an A1C of less than 6%, was only 2% in the medical therapy group versus around 23% in the sleeve gastrectomy group and 30% in the Roux-en-Y gastric bypass. And you can see that the A1C reduction in surgery versus medicine was also statistically significant. Now, what is a good total body weight loss that we should aim for in endoscopy? Where we look at this is the review from the New England Journal, looking at various different randomized controlled trials. These are the high intensity ones, and these are the pharmacotherapy ones. So for instance, you look at Qsimia, you have roughly 55% of the subjects achieve 10% or more total body weight loss, and 75% of the subjects at least receive 5% total body weight loss. And what we aim to get for is a 7 to 10% total body weight loss, because that's what you'll get improvements or see improvements in NASH. Now, the advantages of endoscopic bariatric therapies is that it's less invasive, it's less costly, it's an outpatient procedure, it's repeatable, reversible, and has multiple purposes for cosmesis, treatment for diabetes, as a bridge to surgery. And now when we look at how we divide the therapies out there. The ones that are in the stomach have more an obesity effect, and the ones that affect the small bowel have more of a stronger anti-diabetic and NASH effect. Now, a lot of the small bowel therapies are sort of new and emerging on the horizon. They're still not approved by the FDA. A lot of these are approved. So let's look at the intragastric balloons. So you have lots of different balloons on the market. You have double balloons, single balloons, swallowable balloons, adjustable balloons, balloons filled with gas, balloon filled with liquids. Now, the ones that are approved in the US are these three. Reshape and Obera are balloons filled with fluid, and they're both placed and removed endoscopically. And they had randomized controlled trials where they roughly have similar total body weight loss. The first one was sham controlled, and the second one was just lifestyle therapy. And they work by delaying gastric emptying, so you have a lot of accommodative symptoms of feeling nausea and pain for the first 2 weeks, and that's how you lose the weight. Obalon, on the other hand, is a gas-filled balloon, and you place it via delivery system radiographically into, you put 3 different balloons at 3 different time points, and then you remove them endoscopically. And in their randomized sham control trial, you can see that the total body weight loss was slightly less, although in the real world, and I'll show you the data, it's a little bit different. There's no delay in gastric emptying here. It has more of just the fact that it just is a space occupying device. Reshape has been voluntarily withdrawn off the market, and there is some talk that Obalon may also be withdrawn soon. I mean, COVID has affected us all negatively. So we're really in the US left with 1 balloon at the moment. Sorry, the slide got. Now, balloons aren't without their side effects. They can cause, because of their accommodative symptoms, they can cause pancreatitis, they can cause hyperinflation, and they can cause obstruction. And in cases, there can be procedure perforation, obstruction, and death. And that's why the balloons are contraindicated in any patient who's had any sort of gastric surgery. Also, you have to remain on PPI therapy for the duration of the 6 months. Now, other balloons that are now FDA, getting FDA approved, I'll just move my picture down here, is the adjustable balloon. And so the theory behind this is that it's a fluid-filled balloon with an adjustable strap, so that if you have a lot of accommodative symptoms, you can bring the strap up and take out some fluid. But if you don't have enough weight loss, then you can have another endoscopy and insert more fluid in there. And in the randomized lifestyle therapy, you can see 14% total body weight loss versus 3.6 in the control group. And obviously, this was statistically significant. And because of this, it's now with the FDA getting, hopefully, approval. And the second balloon that's also under review with the FDA is the ellipse balloon, or the procedureless gastric balloon. And this is a balloon where you place it via an oral catheter radiographically. You then inflate the balloon with 500 cc's of proprietary fluid. The fluid stays in the balloon for 4 months. And there is a valve here with the suture that dissolves after the 4-month period. And then the valve opens up, the balloon deflates, and the balloon passes through the GI system. And this is a meta-analysis that was presented last year at DDW, looking at a total of 160 studies. They had 3 bowel obstructions, but they've changed the design of the balloon, and since then they've had no further obstructions. But what you can see here is that the weight loss is similar to other fluid-filled balloons, roughly around 10% total body weight loss at the 12-month mark. And this is their largest data to date that was published now late last year, which over 1,700 patients. You can see that a very small number had balloon removal because of intolerances, and they had 3 balloon bowel obstructions, as we discussed earlier. But you can see the total body weight loss was about 14% total body weight loss. And you do get improvements with that total body weight loss in A1C, cholesterol, triglycerides at the 4-month mark. Now, balloons also show an improvement in diabetes and NASH, and these were 2 meta-analyses that were published now 3 and 4 years ago, showing improvement in ALT as a surrogate for NASH and improvement in A1C by 1% as a surrogate, or just to show diabetes. And in this study that was presented at DDW last year and just published this year by the Mayo Group, this was a trial where they looked at the impact of Obera balloon and liver fibrosis in a paired liver biopsy score. And what you can see here is that patients underwent an MR elastography, liver biopsy, to look at the scoring system. And at the end of 6 months, you can see improvement in weight, in the waist circumference, in A1C by about 1.3%, improvement in ALT and AST, and more significantly that the fibrosis regressed per biopsy in about 15%, and the NAS score also improved by about 2.6 points, 80% decreased by at least 2 points. And because of this, the AGA made recommendations to ensure that the balloons are used for weight loss and that they should be used as a treatment of NASH and NAFLD in conjunction with lifestyle therapy. 2 other devices that were also approved in 2019 is the Baranova, or the Transpyloric Shuttle, which is a balloon that causes intermittent gastric outlet obstruction, essentially. So it works similar to how other balloons work. But basically, this was approved through a randomized sham-controlled trial where they keep this device in for a year. And you can see here that the percentage of more than 5% total body weight loss was 67% in the device group versus 30% in the control. And the 10% total body weight loss was 39% versus 14%, and both were statistically significant. In terms of side effects, they had gastric ulcers in 10% of patients that responded to both PPI and Carafate. They had improvement in hypertension, insulin, and HOMA-IR. And this is the intent to treat analysis. And for protocol analysis, you can see the weight loss is roughly 10% in the treatment group versus around 2.9 and 3% in the sham group. Gelesis is classified as a device by the FDA because it induces weight loss. So it's basically a hydrogel methyl cellulose cross-linked with citric acid. You swallow 2 to 3 tablets or capsules with a glass of water 20 to 30 minutes before a meal. The gel expands in the stomach and makes you feel full. And in their randomized sham-controlled trial, you can see that they achieved good weight loss of 6.4% in the treatment group versus 4.3% in the sham group. And if you look at the percentage of patients that had more than 10%, more than 7%, and more than 5%, all statistically significant. When they looked at patients that had more than 8% total body weight loss, they classified those as the better responders, and they had better weight loss than the sham group. Finally, moving on to plication devices or plication therapy, you have the POSE, which is an endoluminal platform that causes cirrhosis to serosa acquisition. This is the original randomized controlled trial of 13% versus 5.3%. The American trial did not get FDA approval because it didn't have as good a weight loss. So the company sort of redesigned the trial with the POSE-2, sort of copying the surgical sleeve a little bit more, and they called it the belt and suspenders approach, then POSE-2. And in this study here, you can see a multi-center prospective trial that was presented last year and this year at DDW. of 41 patients. And you can see at 9 months, the total body weight loss was 17%. But more importantly, you had improvement in ALT from baseline, and then the CAP score as well from baseline, and we didn't have any significant side effects. Now, the Endomina device is also another application device that's slightly different. This is inserted onto any endoscope, and it was developed in Brussels. And they just published their randomized control trial with patients between a BMI of 20 to 40, randomized 2-to-1. They included 71 patients, and what they showed is that with a crossover, that the procedure group lost roughly 12% total body weight loss at the 6-month mark. And then when you cross the lifestyle group, they lost a similar amount afterwards. They had no significant side effect profile. And finally, the last of the plication devices is the endoscopic sleeve gastroplasty using the Apollo overstitch device. And this study here shows the evolution of the technique over the last 8 years or so, 8 to 10 years, going from technique that copies the vertical banded gastroplasty to interrupted sutures to what we have today, which is a series of continuous sutures from the incisura to the GE junction, and then a second layer for reinforcement. Now, we were fortunate enough to follow our cohort prospectively, and we just published our 5-year data showing durability at 5 years. So this looks similar to what you see with the surgical data. But interestingly, at 5 years, you have 15% total body weight loss, all statistically significant. They nadir at 16.7. It's a day procedure. Patients go home the same day, and you get durable results because of the helical screw that you'll see coming off at the 7 o'clock procedure that grabs muscularis propria by turning around. Patients go home on a modified diet. They're on PPIs for 2 weeks and then advance their diet slowly. In addition, we looked at the impact on comorbidities, showing improvement in A1C in diabetics and all comers, showing improvement in waist circumference, improvement in systolic blood pressure, and improvements in triglycerides and ALT as a surrogate for NASH. And more recently, we published hepatic steatosis index after ESG, showing improvement in that. Sorry, this is the HSI score. And what you can see here is that this is baseline prior to ESG, and at the end of the follow-up, you can see there's a shift to the left with more people having F2 and F0 fibrosis compared to higher numbers before. This is significant reductions in baseline at the end of the follow-up, and this is sort of the significant improvements in ALT, AST, NAFLD score, HOMA-IR, and leptin. We compared our data to surgery, and what you can see here at the 1-year mark is that the surgical group, the surgical sleeve, did roughly very well at 30% total body weight loss versus 18% in the endoscopic group and 13% in the lap band. But what was more important, when you stratify by BMI less than 40, there was no difference in weight loss between the groups, suggesting that the endoscopic sleeve should be a viable option for you. In addition, the significantly less length of stay, everyone goes home the same day, and significantly less adverse events. The Hopkins group also published on this, looking at a case-matched series, but looking at the weight loss at 6 months, and you can see here that the weight loss, again, is better in the surgical group compared to the endoscopic group, but the endoscopic group had a lower rate of GERD compared to the surgical group, which is important because now there's a lot of data on GERD and Barrett's post-surgical sleeve. They also looked at ESG versus high-intensity lifestyle, and you can see here that the ESG group does better than the high-intensity lifestyle at each time point, with percentages of 5, 10%, and 20% significantly more in the ESG than the lifestyle group, and all statistically significant. The learning curve, it takes about 35 cases to do this under an hour, and it takes roughly 9 patients to do it under 2 hours. Another device that has just been published is the EndoZip trial, which basically is a motorized suture system that copies a vertical banded gastroplasty. In a study of 11 patients, you can see that the total body weight loss is roughly 11% total body weight loss, and they had no significant side effect profile.
Well, anything has finally arrived, and it's called Aspire Assist.
The Aspire Assist works by removing a portion of the food from the stomach through a tube before it is absorbed.
So the reason I like using this clip is, you can go Google it later on, but it describes the Aspire really well. And it's basically, if you want to lose weight, you have to aspirate. And it's a tube similar to a PEG tube, but in their lifestyle versus medical therapy, you can see that they achieved a significant total body weight loss, or excess weight loss, 30% versus 11%. And it's durable. This is data for up to 4 years, showing that it's durable. The more you aspirate, or the more you continue to aspirate, the better the results. And everyone knows how to place a PEG.
All right, I think we're going to switch over just to the live cases that they're